I'm David Mooney. I'm the Trauma Medical Director at Children's Hospital Boston. I take care of all the severely injured kids that come in the hospital. If I can, I respond to see them in the ER, and then take care of them while they're here, and then see them back in trauma clinic. Our trauma program is one of the largest trauma programs in the U.S. We see more injured kids every year at our hospital than any other hospital north of Philadelphia. Right now in Massachusetts, about 45% of the kids who get admitted to any hospital in our whole state get admitted here. We see about 12,000 injured kids a year in our ER and admit about 1,200 kids a year. We admit children from the eastern half of Massachusetts, northern Rhode Island, southern New Hampshire, and from the southern tip of Maine. And we have in the past year, over 45 different hospitals referred us patients. A large group of hospitals that are scattered over a broad geographic area. Children's is a freestanding children's hospital that works with a lot of hospitals but doesn't have that kind of corporate relationship. And for us, it's broken down a lot of those walls between institutions where we're able to get the images from people that, again, we may not even work with in other ways. If the patient is coming, even if they're from northern New Hampshire, we can get their images long before they arrive. All of our communications go through our Emergency Communications Center. And lifeIMAGE has become one of the pieces of the package of information that other hospitals send when they send us a patient, which has been great for us. We have 18 surgeons that take trauma call. We have not had to educate them in the use of lifeIMAGE because for us it's become seamless. The images just flow into our system and we look at those images the same way we look at other images. One thing that's been very nice for us is that for us it just happens. While the communication specialist is talking to them about the patient's name, their date of birth, their injuries, they're sending instructions to that hospital on how to load the images, and then they walk them through the process so that they wait to collect the data prior to ending the phone call. That allows, for me, that allows me not to even worry about what's happening on the other side. Because again, our comm center has been pulling off the details. Once we got to the point where people were starting to get educated, the day finally came when it was available and we could load images and see images from outside hospitals. Within 3 weeks, we had 2 critically injured kids that benefited from the system. In one case in particular, a toddler came in from an outside hospital with a critical epidural hematoma, where the child, if they weren't rushed right to the operating room, could die. And with lifeIMAGE, we were able to see in advance of the patient's arrival that yes, this was an epidural hematoma, yes, it was one that required an operating room immediately. So we were able to bring that child right to the operating room, bypassing the ER, bypassing all the delay in the processing of the images here, trying to find a computer to load the disc on, hoping it would load, and then setting up the operating room. We're able to do all that in advance because we could see the pictures in advance. And then another child, very similar situation, but because we were able to see the pictures, we knew that we should not take that child right to the operating room, that they should go get a pressure monitor put in their head, and once the ICP switch was in, start aggressively managing their brain injury instead of spending the time trying to figure out whether we should go to the operating room or not. And so right away we had 2 kids who immediately benefited from lifeIMAGE. I mean, the one thing to me that's been great about this is that for us it's seamless. We really haven't had to change anything for the trauma surgeons or for the nurses or the ER docs or the neurosurgeons. Our workflow, our work style, everything has been the same except that now we see the images. And we can plan. And planning ahead for a trauma patient is key, especially for a critically injured trauma patient. We get the neurosurgery attending in from home. The OR is standing there ready. We know what we're going to face. We know the equipment we'll need. And all of those things that tend to drive you kind of crazy when you're in a hurry trying to get everything ready with a lot of people involved can be done much more casually over the time while the patient's being brought in, rather than in a flurry of activity at the last moment, which in that flurry, patient safety risks go through the roof, communication problems, errors happen, and being able to avoid that frenzied moment has been very big for us.